Hello, I'm Dan Cox, a professor of counseling psychology at the University of British Columbia. Welcome to Psychotherapy and Applied Psychology. Today, I'm thrilled to welcome back Dr. Ueli Kramer, a world-renowned expert in personality disorder treatment. In today's conversation about personality disorder treatment, we'll discuss therapist responsiveness, case formulation, the therapeutic relationship, and much more. If you enjoy this conversation, feel free to leave a comment below, and we'd appreciate it if you hit the like button and subscribe to the channel. This episode starts with Dr. Kramer responding to my question about how he thinks about the interface between the change process that clients go through and how therapists can facilitate that change process. Let's dive in.
So, process research has kind of gone back and forth between the two, or also there's this huge book edited by Clara Hill and John Norcross came out last year on 40 or so meta-analysis on different interventions and therapist skills. And actually, the quite disheartening conclusion is that there's something like 9 interventions, therapist interventions or skills that are relating with outcomes, client outcomes, right? Which is, I said, disheartening or kind of, a little bit frustrating after all this work on like 500 pages, that you can dress this list of 9 interventions, which, we all knew their kind of work, but, and of course it is, it's only an invitation for more research, but also to really think about what type of research would be helpful. So let me pause here. That's one way to look at it, right? I mean, it's kind of a way, that the therapist would actually do the job and, kind of like a mechanic, go to the car and kind of change here a little bit, change here or something. And then we hope that the car runs again with all the expertise he brings into the understanding of how the car works. But it creates a lot of problems. It is usually done within therapy schools, that one technique is only actually studied within one particular therapy approach, and we don't know if you export it, whether it will still work. Let's say giving homework is helpful for CBT or DBT, Dialectical Behavior Therapy, for borderline personality disorders, one of the most heavily studied treatments for personality disorders, the heavily studied with very good effects, very precise predictions of outcomes and dropouts. But we don't know if it would work in psychodynamic psychotherapy because it's a whole different context of interaction, a whole different style of relating and of working together. So it doesn't translate easily if you just have a technique and you kind of put it somewhere else, right? There's a contextual factor, obviously. So a different way to look at it is to start with the client and just to ask yourself, what are actually client processes that may be central? And of course, I've been doing quite some research there, and it's really based on my own the intuition comes again from my observation of how clients change, like what I see in my practice, and then I think about it with colleagues and ask myself, what is it, right? And one of the change processes that you can observe in the therapy hour is emotional change, right? And it's probably one of the core features of any human being, if you accept evolution theory, that we are human beings and even animals, but human beings in particular, because we have the capacity to put words on our symbolizations, that actually we can say what we feel, or what is there, is that we, in response to interpersonal situations that are important for us, it's not just any situation, right? That that if I see the face of my mother as a child, I have a reaction. If I see some kind of beautiful landscape that's actually reminding me of vacation when I was a child, I have an emotional reaction. And these emotional reactions, and if I see you, we're talking together, we have also mutual reactions because we affect each other. So there's a whole, like, our life is emotions, right? We are driven by emotions, really. So that's also, and I know you have invited Antonio Pasqualeone, my dear colleague and friend, and I think a lot of what he mentioned is something that I, of course, want to study in the treatment of personality disorders and beyond. So this is just to say that this is one of the core pieces of when we observe clients that drives change, is my assumption, and I think has been to some extent confirmed by different research programs. But it's a very broad assumption finally, so it's maybe not very specific yet. But of course, that this is a different way to look at things. And then the final way to look at your question, should we start with the client or the therapist? But then it's actually the responsiveness, the idea of, that you that the therapist may have an idea of what to do, may have a program or a plan, and then the client comes in and presents something completely different, which is the usual business when you treat clients with personality. So that's why I think it's a concept that has a good potential to understand, explain the effects of treatments for personality disorders, responsiveness. And so then the therapist needs to revise and come up with a new explanation and kind of revise his case formulation and maybe reroute, go to a different aspect depending on what's happening in the treatment.
I sort of think, after sort of listening to you and thinking and reading some of your more recent work, I think maybe the way to dig into this is to maybe go down the responsiveness road. So I wonder if you could give us just a very brief sort of like, what is responsiveness?
Yeah.
And then I really want to dig into how you think about this when working with folks with personality disorders.
Mm-hmm. Mm-hmm. Okay. Yeah, of course. This is what is responsiveness? I mean, this has been discussed under different names, I should say. Also, when Gordon Paul in the 1950s, from a research perspective, asked the question, what treatment is the most appropriate for this particular person, under which circumstances and so forth. There's more to it. But really the notion, what he wanted to get at, is that we can't just study psychodynamic interpretations and look at them under a glass, right? It's all in a context. And if we really want to understand how psychotherapy works, we need to take into account the complexity of the interaction in the interactional perspective. So this is what's been up to psychotherapy researchers as a challenge since 1950s, but we have not really come up with good models. I think we have always studied linear models, or kind of trying to explain it differently in a simple model. So, and
I think, sorry to interrupt, but I think that this relates to what you were talking about earlier with the Hill and Norcross, sort of this idea of, if we just think about homework, for example, or thought challenging, or interpretations, that those are just behaviors a therapist does. But when we look at them acontextually, when we look at them without considering, okay, who's the client? What does the client need in this moment? What's our goals? Like if we just say like, oh, how helpful is what's the correlation between interpretations and some sort of outcome without considering that context? Well, that sort of misses the whole thing. That it needs to be contextualized at the bigger picture for this particular client, but also in this moment, it needs to be contextualized.
If you talk about correlations, there has been studies, and also Bill Stiles talked about it already in the 90s, showing that there can be a negative correlation between psychodynamic correlations and the outcome. So the more a therapist proposes interpretations, the less good is the outcome. So the question is then, does that mean that this particular intervention should be avoided and is harmful, right? I mean, this could be concluded, which of course would be nonsense because we know it's very helpful in certain situations, but maybe more tricky in others. And in particular, for this particular case, can be the case, imagine a client that is just very difficult in terms of understanding what the therapist is meaning, right? The therapist may have to repeat more times than once his or her interpretation, which brings this score very high up, but it doesn't mean it's bad therapy. It's actually very good therapy for this particular client. So this is just to put everything a little bit more into context. So really it is using the information from context and being aware that it is the intervention of the therapist is affected by this context. So this is how Bill Stiles defines it. This is many other colleagues have defined it in a similar way, therapist responsiveness. But there has been a second part to your question, how we actually could conceptualize responsiveness for personality disorders, right? Is that what you want to get at?
And I think it's, it's interesting, particularly with personality disorders, because I think, at least in North America, DBT is sort of the thing. And so folks, I think there is this tendency for us in our training, our practice, to really be like, oh, this client needs DBT. And that is, and I'm not trying to, because I think DBT is great. But I think in some ways we do think about it more mechanistically rather than responsively.
Well, actually, I would argue, just with the fundamental definition, responsiveness acts on all time scales. And what you say is mechanistically may actually also be responsive in some sense, in a very broad way, in the sense that we do have a diagnosis. We have a client in front of us that presents certain features. It is totally, at least as a first approach, defendable to propose dialectical behavior therapy for a client with severe personality disorders that could be qualify as well as borderline personality disorders. So, this is totally state of the art. So I would not question that. For me, it's not, in any way, not consistent with what I said before, but it's just a broader picture of responsiveness. What I meant earlier, and what's really interesting, I think, for these clients, these folks, is to think about responsiveness from a moment by moment perspective, which can be observed in DBT or in other treatments, in any treatment, of course. This is interesting because we know that there's a lot going on in these treatments, right? When you just have a look, and I've looked at a lot of tapes over the years, rating sessions from my own group or from other colleagues, doing all kinds of different treatments for patients with borderline personality disorders or any personality disorder, that these treatments, and that's also a way to say again, this is really fascinating, right? It's extremely rich material from a clinical perspective. These clients do everything in one session, like you name it. You say anything and they do it, right? And the therapist, a good therapist, is acting in a very varied way. And just to take up again your example of dialectical behavior therapy, dialectical behavior therapy is a very responsive treatment. It has a lot of very varied components in it, in particular individual therapy, where the therapist is sometimes very empathic, but at other moments actually very irreferential and actually uses humor or metaphors or has specific techniques that he or she uses to have a shift in attention in the client that's quite remarkable. It's not just one way of relating. There's different types of relating. For example, in DBT, or just the tasks or the interventions that can be proposed can be very, very varied.
Can you talk more about those different ways of relating and what that looks like in terms of when a therapist is being particularly responsive?
So again, let's take a patient who comes in, sorry, with with a difficulty in making a case for his employer. Like, client comes in, he or she wants to change something in his contract, get a pay rise, or something that would be helpful for him, but he or she does not dare to do it, right? For some kind of reason. So this could be a problem. This is an interpersonal problem, but the therapist at the first level would probably just express some kind of validation that this is difficult, but then also see what kind of skills, we don't know who this client is, but kind of support and reinforce certain skills that are already there, right? So this is something you have used, and kind of that may be two aspects of responsiveness, like both validating that it's different types of validation can be used in DBT or in other treatments, and also propose some reinforcement of what's already there. And then, of course, in DBT, because it's a change-oriented or problem-focused treatment, teach new skills that can help the client move forward and actually get to his goals or their goals. So this is one thing. And there's another way of, let's find a client who says, I don't really know what to do. I don't know if I really want to stop any behavior, let's say self-harming, or if I want to continue. So there's kind of ambivalence. So in some of these situations, what in particular when the therapist feels stuck, it can be helpful to use humor or irreverential statements, which is a different way. It's also in some ways responsive, right? It's responsive to the clinical presentation of the patient, right? So it's a different way of working together. So I'm just giving you a whole lot of techniques which are actually studied in the book by Hill and Norcross. So these, you could just look them up and see, oh yeah, this relates to outcome, this doesn't. But what I mean by this is, what these examples is that in the same session you can find everything I just said. Because clients, they shift from one moment to the next. Right? So it requires some kind of skill in the therapist that can be broadly named responsiveness.
Mm-hmm.
But of course, if you study it, it is also responsiveness, right? It's a little bit a mix between two words, but you can study the phenomenon, but you can also train the therapist in perception skills and intervention skills. Perception skills to understand what is the event that the client presents, and intervention skills. If this event is there, what can the therapist do at this moment? Which type of intervention is a good one, is responsive? So I think this is the type of, this is also consistent with research which we have done. Maybe I can talk about that, but responsiveness is it's an overarching concept under which really the idea of, if there's an event the client presents is present, what is the therapist action that should follow, given the context?
Yeah, and I was thinking about, I think it was in your 2020 paper where you talked about the process of change for clients in personality disorder treatment. And I think it was in that one. I've read some, they blend together. That you talked about how the interpersonal, like the focus on the therapist varying their interpersonal process. And you talked about, I think it was specifically in relation to dependent personality disorder. But really, so I guess, do you have any general framework or way of thinking about how a therapist, a framework a therapist could have so that they could be interpersonally responsive? So just interpersonally responsive, not responsive in other ways. to patients with personality disorders in ways that are effective. Does that make sense? So, like, I often think about sort of the literature on when people act in certain ways, it pulls for us to act
Mhm.
in certain ways, right? And so there's this general argument that one of the values for that one of the things that therapists can do that can be helpful is disrupt that,
Mhm.
right? And they might have to fight their own tendencies
Mhm.
to act in typical ways when a client is really angry and yelling at me to respond in whatever way would be typical, but to act in different ways to create
Mhm.
these unique learning moments and that sort of thing. So I guess in that larger framework, have you sort of come to any ways of thinking that you find is helpful for therapists when working with clients so that they can be interpersonally effective with them based on, does that make sense?
Um, so I would come back to how to conceptualize clients first using case formulation and how this can affect the therapist intervention. I'm not sure this will address your question, but I've done obviously lots of research on plan analysis that's been developed in Europe by Carver and Kaspar, which is a way to conceptualize patients' problems, a case formulation method. So the piece that's interesting there, I'm not going to go give like a whole class on this, but really the piece that's interesting is that it differentiates between what you observe in the client from hypotheses that explain the purposes of these behaviors that you observe, behaviors and experiences. So, for example, a client may present in session as interpersonally challenging, or maybe not decide not to talk, right? Then the question would be, what's the purpose of this client behaving in this particular way? Of course, now I can't, answer this question generally, but for a particular client, you can imagine he may have a plan that's not conscious, but just kind of a construction for you as a therapist. It's helpful in that sense. That says avoid trusting the therapist, or even you know um, present as somebody who is particularly difficult in this particular situation, or just different aspects can explain this particular behavior. If you um, if you ask your questions in a in a specific way and kind of conceptualize this case, you will arrive at one moment to acceptable plans that are the motives that drive the behavior and the problematic plans, right? As soon as you arrive to these acceptable motives, you will have a level where you can intervene using um, an effective therapeutic intervention. That is the motive-oriented therapeutic relationship. That's not a new therapy, but that's just when you do a case formulation, then you have a way to interact with the patient. Basically, the example you gave, that you actually open up a new space between you and the client. That there's some way that you, as a therapist, you take away the motivational basis of some of by your action that is within, of course, the framework of the therapy, um, take away the motivational basis of the problematic behavior. And the patient criticizes you that this is not needed anymore, that he feels sufficiently safe with you. So it's not a technique that's extremely complicated. It's just a principle that actually a lot of therapists use. We have done studies on therapists who have not learned this, but who have a good level of expertise in any therapy approach, different therapy approaches. A lot of therapists, they do that. They use this principle to some extent, but of course it can be trained in trainees, which is really interesting.
Mm-hmm.
I think about early first year trainees in psychotherapy, and they get exposed to very difficult clients with the motive-oriented therapeutic relationship. They get a handle right away. to actually keep these patients in therapy, and they feel more comfortable working with difficult clients. So this is a way to use responsiveness in a very concrete and effective way that the therapist also gets a handle of how to work with patients that are interpersonally challenging.
Can you help me understand what you mean when you say take away the underlying motive?
Um, so this has been very quick. So I will have to give a little bit more explanations, I realize. So the idea really is, let's imagine again a client comes to, it's a different examples, comes to therapy, couple sessions in and says, I'm done. I think I don't need therapy anymore. So the question is, what is the purpose of him or her saying this? It may be that there's some anxiety, so he wants to avoid further deepening of a topic. It may be that actually he or she is already satisfied with the results, but it may also be to really keep the therapist at some distance. Right? These are all explanations that I could formulate as possible explanations of one particular behavior, patient behavior. Right? If it's something that's related with avoidance, that's serving the purpose in this particular client to protect integrity or self-esteem or something like that, to avoid being confronted with some negative affect, for example, right? Then the therapist, if this is acceptable, and I'm going very fast, this is usually quite a detailed process of formulation, then the therapist can ask oneself, well, is this a motive that I can work with and accept in this particular therapy hour for this particular client, or is it interfering with further progress? So I can decide this avoid negative affect. I cannot guarantee, but I can at least make a proposal to the patient as a therapist and tell him, I can actually understand a negative affect. We cannot completely avoid it, but please let me know if it's unbearable or if it's something too difficult for you. If this is, kind of proactively actually giving this control to the patient and offering, kind of serving this particular motive of controlling the self-esteem and so forth, that this can be done proactively by an intervention by the therapist. So this is the therapist intervention that is addressing the what we understand as being the motive or the motor, if you want, of the problematic behavior. If it is problematic, that is the patient saying, I am done with therapy, I don't need anything more. And this particular intervention may first look as quite off topic. It's typically the case because we haven't talked about that in this particular sentence. But the patient, if it's the right intervention, the patient will feel understood. And it really goes at the core of what the patient experiences. So my experience with these types of interventions is that if they're really done in a good way, and that the patient feels very welcome and may really open up much more after these interventions.
So when you explain this, I hear, I don't know, two broad things that are happening. One is to work with that motive to then facilitate the work that we're doing.
Mm-hmm.
The other is that therapeutically attending to that motive is the work.
Yeah, of course it can be both, right? But attending to the motive, I would say we just, as a therapist, first of all, serve the motive. That means I'm really thinking of what do I as a therapist have to do explicitly by saying or by doing, right? I can also implicitly give more space to to the patient in the therapy hour to make him experience that what he's developing is actually consistent with his self-esteem, for example. That's the issue, right? Or I can make it explicit if I feel this is needed. So there's different ways I can do that. What the data actually shows is that the implicit aspects are much more predictive of the therapeutic alliance and outcome compared to the explicit ones.
What do you mean?
The implicit ones are the perverbal and nonverbal aspects. So if the therapist is able to convey in a convincing fashion that this motive of the client is the one he focuses on and respects, we're not questioning it, right? While the problematic behavior may be problematic, but the motive is something we're serving directly as therapists. This is kind of the truth in what the client is presenting, right? There's just a little piece of truth maybe in it. That this is something that is the therapist is resonating with, and the client experienced this as something validating, right? Then the theory as proposed suggests that this will reduce some of the interpersonal problems in the therapy hour, right? And open up new spaces, new topics, and new trust in the therapeutic relationship. Our studies have shown that for severe personality disorders, this is actually what happens, that the alliance is getting better for patients who receive this type of intervention, and also depression, anxiety symptoms go down more. Not the borderline symptoms, but the depression, anxiety, general symptoms go down more in patients who receive the motive-oriented therapeutic relationship compared to those who did not receive it. So this is I think a basic, specific way of offering attention, empathy. Of course, you can offer attention, empathy to anything as a therapist, right? This is, humanistic therapy. But for clients who are extremely disturbed, it may not be enough. It may even, provoke difficulty. For some clients, this is too difficult to receive this very strong empathy for everything they do. They know something is not right, right? For patients with personality disorders. It's more complex than that. So the motive-oriented therapeutic relationship just gives specifically an unlimited empathy to one particular piece. That's the underlying motive of the behavior. And everything else, it's not reinforced nor given attention to in this moment.
You've written about mentalizing and metacognition in terms of what changes in clients with personality disorders. Do you think about what you're talking about here in relation to those constructs at all?
So this is really an individualized conception of the therapeutic relationship, what I just said, because of course what I would do with a case like Caroline is different than I would do with another case, right? It depends on how I conceptualize the case, which I think is really the huge potential for the next 10 years, that we can do our assessments for patients with personality disorders, not only on specific variables such as mentalizing or emotional awareness or emotional, the capacity to put oneself in others' shoes, which can be, variables that we can measure, but that we use all these variables and that we get a good sense as a therapist and also as a researcher to what is the profile of this patient. If we do this, we have published one paper that's methodologically quite sophisticated using cross-panel prediction analysis. But when we look at the case formulation as a predictor for this, it's quite complex. It's published in Personality Disorders APA Journal 2022. We can also use case formulation. The bottom line is we can also use case formulation as a predictor for these quite complex models. So case formulation is not only the individualized conception of personality disorders, is not only usable as for clinicians, but may also be helpful for researchers to really get at the core of each of the patients they have in their sample.
It seems like in the last few minutes, it seems like it'd be worth maybe helping the practitioner who's listening think, but when you think about case formulation with folks with personality disorders, you've talked about it a bunch, but more explicitly, what does that mean? How do you think about doing that in a useful way?
Mm-hmm. So you could do it in different ways, and just the bottom line is observe, right, and infer, and then of course use this information, both what you observe and what you infer, proactively in the relationship, right? All the examples I've given before on the DBT, on the motive-oriented therapeutic relationships, and there may be others, is always always the same principle. And to be aware that each step has their own problems or limitations, but also just potential. So I would probably just observe it by writing down what I observe in the patient. What do I see? What is it that's there? And then develop hypotheses. What is this? Why does he do that? What's the purpose in the plan analysis approach? Or how can this relate with my constructs, mentalizing or emotional regulation? Or what does it mean for my theory? And then how can I intervene with the interventions I have?
And how have you found to test those hypotheses with patients?
So psychotherapy is an ongoing falsification of hypotheses. So that's the beauty of it, right? We as therapists create ideas, and sometimes it can be quite frustrating, frankly, to propose a new ideas to a patient who tells me, no, you're actually not right. This is not. Even if you have written about it, it's not what I feel, right? And that's exactly where I think it's so important to then stop and actually listen to the client and say, so can you do it yourself, or can we do it together? How can you correct this, or how can we understand it better, more close to what is your experience?
Got it. So one of the things I always like to ask folks is if they've experienced any pushback for their work.
Not so much. When I submit a paper, I always get reviewers may not like exactly what I write, but this is part of the game. No, I wouldn't say there's no pushback. Of course, if I say these kind of things about integration, of course, this is can be understood in a way that is this criticizing some of the therapy schools that we have established that we're cherishing so much. This could be a pushback. I haven't received that explicitly, but I understand that and I also respect actually my colleagues who really are in one particular school of therapy, approach of therapy, which really cherishes also that diversity of therapy approaches. Otherwise, I'm ignoring it. So, which is also a good place to be in some sense.
Yeah, just naively moving forward.
Yeah.
So, are there one or two resources that you think would be helpful for listeners who wanted to dig more into what you're up to and what you've been doing and what could be helpful?
So maybe just, we didn't talk much about mechanisms of change, but this is all kind of coming together in the book that I wrote with Shelley McMahon and Ken Levy from a variety of perspectives, actually, the book that came out this year, the American Psychological Association, Understanding Mechanisms of Change in Psychotherapies for Personality Disorders. So a lot of the stuff we talked about today Case formulation is very present from a variety of perspectives. Theory, what's the clinical theory doing in all this? All the new dimensional constructs, how we can understand it, is all in there. Using 6 cases, we really dig down into 6 cases and wanted to really exemplify the clinical work, actually exemplify what we think about psychotherapy and how it works using 6 cases.
Thanks so much for watching this episode of Psychotherapy and Applied Psychology. If you found it helpful, please like the video and subscribe to the channel for more insights on applied psychology. I'll see you in the next video, where we continue exploring the science of psychotherapy and applied psychology.